Thank you very much. And thank you very much for the invitation to this webinar, and which are actually famous now. The Myanmar webinars are famous in Geneva, in WHO Geneva headquarters. I'd like to congratulate to the Myanmar team in the WHO office of Myanmar for the lovely organization and exquisite organization of this series of seminar. So I'm here today to talk about the assisted vaginal birth, to optimize use, but also the global challenges that are that we are facing for the appropriate use. So let's start with assisted vaginal birth, which is also known as instrumental or operative vaginal birth, refers to the vaginal birth that is conducted with the help of an instrument, and the most used instruments are there, the vacuum and the forceps, and the reasons for using an instrument are multiple. Sometimes there is a prolonged second stage of labor, sometimes there is maternal exhaustion or fetal distress when the head is deeply engaged in the birth canal, and these instruments can be used to accelerate or facilitate the last part of the childbirth. And assisted vaginal birth cannot be studied without studying or without mentioning of the cesarean section. Both procedures are emergency obstetric care, and both go hand to hand. Assisted vaginal birth can reduce maternal and perinatal morbidity and mortality without resorting actually to cesarean section in the second stage of labor, which is when a cesarean section has additional associated risks compared with cesarean section in the first stage of labor. This simple fact may be particularly or crucially important in low research settings where women and babies have limited access to high quality obstetric care and low access to the resolution of the complications that may arise. Assisted vaginal birth is, like I said, very important, and WHO actually considers assisted vaginal birth as one of the 7 basic functions for obstetric care. This means that if a hospital wants to be called, providing basic obstetric care, they actually should be able to perform assisted vaginal birth. Similarly, a cesarean section is one of the 9 comprehensive essential functions for comprehensive services. And cesarean section needs to be conducted if the hospital is named themselves as a comprehensive service. Now, after this introduction, I'd like to actually pass the floor to my WHO team in Myanmar, so we can do a few questions using the Mentimeter, which will help us to understand and to know what we are using in Myanmar. Please.
Thank you, Dr. Ana. So, dear attendees of the webinar, as mentioned by Dr. Ana, we would like to seek your kind responses regarding to this topic of assisted vaginal birth through the Mentimeter questions. We would like to ask 3 questions. So please, So please open your the browser on your phone, on your laptop, and also please type menti.com. And there will be a box to enter the code. The code is here. You can see 25323811. Please enter this code. Assisted vaginal birthနဲ့ပတ်သက်ပြီးကျမတို့ဒီဆရာတက်ရောက်နေတဲ့ဆရာမတွေကိုမိကို3ခုမေးချင်ပါတယ်ဒီမိကိုလေးတွေဖြေဖို့အတွက်ဆရာမတို့ရဲ့ဖုန်းဒါမှမဟုတ်ရင်ကွန်ပျူတာရဲ့ browser ကိုဖွင့်ပြီးတော့ menti.com လို့ရိုက်ထည့်ပေးပါအဲ့ဒါဆိုလို့ရှိရင်code number တောင်းတဲ့ page လေးမြင်ရပါလိမ့်မယ်အဲ့ခါကျရင် code number 25323811ကိုရိုက်ထည့်ပေးပါရှင် So we will go to the first question. The first question is the assisted vaginal birth used in your hospital or setting? If you do, please answer yes. And if you do not do assisted vaginal births at your hospital or at your health facility and do cesarean section instead, please choose the second answer. အဲ့တော့ပထမမေးခွန်းကတော့အခုလို assisted vagina birth ကို birth လိုမျိုး faucet တို့ vacuum နဲ့မွေးဖွားခြင်းတွေကိုဆရာမတို့ရဲ့ health facility တွေစက်ရုံတွေမှာအသုံးပြုကြသလားပြုလုပ်ကြသလားဆိုတာပါအဲ့တော့ဆရာမတို့ရဲ့စက်ရုံ health facility တွေမှာဒီ assisted vagina birth အတူကောက်ပြော AVB ပေါ့နော်ပြုလုပ်တယ်ဆိုရင် yes တို့ဖြေပေးပါတကယ်လို့ဒီလိုမျိုးပြုလုပ်လို့မရှိဘဲနဲ့အဲ့ဒီအစား cesarean section ပဲပြုလုပ်လို့ရှိရဆိုလို့ရှိရင်တော့ no ကိုဖြေပေးပါရှင်ကျမတို့အဖြေလေးတွေရဖို့ခဏစောင့်ပါမယ်
So there is an overwhelming majority for now who is saying that they use assisted vaginal birth in their hospital or setting. Even if they don't, even if you don't do it explicitly, if other colleagues do it, you should answer yes. So we know what's happening. Okay.
Dr. Ana ပြောတာကတော့ဟိုဆရာမတို့ကိုယ်တိုင်မဟုတ်ပေမဲ့လည်းဆရာမတို့ရဲ့စေယုံဒီမှာဒီလိုမျိုး assisted vagina birth ပြုလုပ်တယ်ဆိုပြုလုပ်တယ်လို့ဖြေပေးလို့ရပါတယ်ကိုယ်တိုင်ဒီ AVB ကိုဟိုပြုလုပ်တာမဟုတ်ပေမဲ့လည်းကိုယ်စေယုံမှာဒီလိုမျိုးလုပ်တာမျိုးရှိရဆိုလို့ရှိရင် yes လို့ဖြေပေးလို့ရပါတယ်ရှင် We only have like 28 responses now. So I would like to again remind all the attendees, if you haven't entered the menti.com in your browser, please enter menti.com and please use the code here 25323811 to answer this question, please. We will wait maybe for a minute.
I think we can move forward if you want. You know,
yes, Doctor.
It's very clear that assisted vaginal birth is used in Myanmar, at least
Thank
among this audience.
Yes. Right. Thank you very much for your response. So we will move to the second question. So the second question is, for assisted vaginal birth, what type of instrument is used predominantly in your hospital or setting? If you mostly use vacuum delivery, please choose vacuum. If you mostly use the forceps assisted birth, please select the forceps. And if you equally use both vacuum and forceps, please choose both. Or if you do not use AVB at all at your hospital or setting, please choose the last answer. အဲ့တော့ဒုတိယမေးခွန်းကတော့ဆရာတို့ရဲ့ health facility တွေစက်ရုံတွေမှာဒီ AVB အတွက်အများဆုံးအသုံးပြုလို့ရှိတဲ့နည်းလမ်းကိုမေးတာပါ vacuum ကိုအသုံးပြုပြီးမွေးတာများလား assisted vagina birth လုပ်တဲ့အခါကျရင်ပေါ့နော် forceps ကိုအသုံးပြုတာများလားဒါမှမဟုတ်ရင်နှစ်မျိုးစလုံးကိုအတူတူတော့ပဲအသုံးပြုလို့ရှိလားဒါမှမဟုတ်ရင်နှစ်မျိုးစလုံးကိုမသုံးတာ AVB ကိုလုံးဝကိုပြုလုပ်လို့မရှိတာလားဒီအထက်ကရွေးပေးဖို့ပါ
So we have, you know, reached even more answers than in the previous question. And it seems that in the hospitals of the audience or the setting of the audience in the seminar. Either both, the majority of the answers go for both. So there are skills acquired in the hospitals for both, or, vacuum in the majority as opposed to forceps. There's only a few with where only forceps are used. Okay.
Shall we move to the last and third question, Dr. Ana?
Yes.
Okay. So the last question is, what are the 3 most important barriers to assisted vaginal births in your hospital or setting? There can be more than 3 barriers you may face, but please choose the 3 barriers which you think most important and most challenging for you. So these can be, the options are like fear of litigation, lack of functional equipment, lack of clinical guidelines, lack of training and support, financial constraint, or women don't like ABP or accept it, or you have concern with the complications. So please choose 3 most important. တတိယမိကုံကတော့ဆရာတို့ဆရာမတို့ရဲ့ health facility တွေစေယုံတွေမှာဒီ assisted vaginal birth ကိုလှုပ်ဆောင်မှုvacuum ကိုအသုံးပြုပြီးတော့ faucet ကိုအသုံးပြုပြီးတော့အသုံးပြုပြီးပေါ့နော်အသုံးပြုတဲ့အခါမှာအခက်အခဲအတားအဆီးရှိနိုင်တယ်ပေါ့နော်အဲ့ဒီနေရာမှာအရေးကြီးဆုံး3ခုကိုရွေးပြရမှာဖြစ်ပါတယ်ဒီ ABP ကိုလုပ်ဖို့အခက်အခဲအတားအဆီးက3ခုထက်လည်းပိုနိုင်တယ်ဒါပေမဲ့ဆရာဆရာမတို့ရဲ့context မှာပေါ့နော်ဆရာဆရာမတို့ရဲ့အခြေအနေမှာအရေးကြီးဆုံးဖြစ်တဲ့လို့ထင်တဲ့ဒီအခက်အခဲအတားအဆီးလုံးမျိုးရွေးပေးရမှာဖြစ်ပါတယ်။ဘာတွေရှိနိုင်လဲဆိုတော့ဒီ ABP လုပ်ပြီးတော့တစ်ခုခုဖြစ်လို့ပြဿနာတက်တာတရားစွဲတာမျိုးဖြစ်မှာဆိုတာလား fear of litigation ပေါ့နော်။ဒါမှမဟုတ်ရင်vacuum တို့ faucet တို့ကိုအသုံးပြုပြီးတော့မွေးဖွားပေးဖို့ဒီ functional equipment လိုအပ်တာလား။ဒါမှမဟုတ်ရင် clinical guidelines တွေလိုအပ်တာလား။သင်တန်းတွေပံ့ပိုးမှုတွေလိုအပ်လို့လား။ငွေကြေးအခက်အခဲကြောင့်လားဒါမှမဟုတ်ရင်မိခင်တွေကvacuum တို့ faucet တို့နဲ့မိုးရမှာမကြိုက်လို့လက်မခံကြလို့များလားဒါမှမဟုတ်ရင်ဒီလိုမျိုးမွေးဖွားပြီးနောက်ပိုင်းနောက်ဆက်တွဲယောဂပြဿနာတွေအတွက်ဆိုရင်လို့လားဒီချက်တွေထဲမှာအရေးကြီးဆုံးလို့ထင်တဲ့3ခုကိုပေးပြရမှာဖြစ်ပါတယ်
So very interesting. I understand that, maybe in your setting you have the 7 barriers and you see some of each of the 7, but here we were just trying to understand what the most important are, and that's why we wanted you to just pick on three that you consider being the most important. By far, we have a winner, which is the concern with the complications. So, you consider that the complications are, probably more difficult to overcome than choosing a cesarean section. And also the lack of training and support, which is related with the concern with complications, as well as the lack of functioning equipment are here seen the most important barriers. Women don't like it or don't accept it, but not as much as the others. So the other 4 reasons are clearly behind to these 3 that you have been selecting. Very, very interesting, the concern with the complications. Very good.
Yeah, good. Thank you for your kind comments, Dr. Ana. I think we can now move back to the presentation. No?
Yes.
Thank you very much to all the attendees for actively participating in this multimedia questions. From your response, we have these useful insights on the use of assisted vaginal birth and your perspective on the barriers to use ABP. And may I hand over the floor again to Dr. Ana to continue the important presentation on ABP. The floor is yours again, Doctor.
Thank you. Thank you very much for your active participation. It's very good. It helps me to put the presentation also in context to understand what your concerns are or what your views are from assisted vaginal birth in your hospital, in your country, in your setting. So going back to the presentation, I said before that you cannot study assisted vaginal birth without actually studying a cesarean section, because they go hand to hand. And here I wanted to show you a graph that I already showed back in September in the other webinar, which is how cesarean section rates have been increasing in the last 3 decades. WHO has monitored the use of cesarean section during the last 3 decades worldwide. And, there is a clear trend on increased use of cesarean section as a mode of delivery. And I know this graph maybe, is a little bit vague and, there's no reference. And also the WHO does not have any recommendation now on the ideal cesarean section rate. WHO consider that there is not ideal cesarean section rate, but if we put in the graph the historical 10 to 15% of cesarean section rate, which was considered acceptable, you see that all the regions have surpassed, except for Africa, that range or that landmark or threshold by far. And we can see the Latin America and the Caribbean, which at regional level, the rate of cesarean section goes above 40%. This graph goes back a few years, and obviously these numbers have changed and have actually increased, unfortunately. What WHO has recently, last year, published projections. So what does it look like, the cesarean section use in the future to 2030? No change. You can see here that cesarean section rates will continue to increase, and these graphs show the deep increase. These graphs are for each of the regions, starting in the left top is the world, then in yellow Africa. The one that could interest you for your closeness is the one in red, which is Asia, which actually has the deepest increase. If we look at this graph a little bit closer, we'll see that the regional averages go from as high as 63% expected in 2030 to as low as in Central Asia, 13%. Myanmar is in the Eastern Asia with an estimate or a projection of about 25%. And Myanmar right now has a national average of 17%, which is, not very high in comparison with the others. But unfortunately, an overall rate for the whole country cannot tell us if the women who need the cesarean section actually are getting the cesarean section. And moving into the assisted vaginal birth picture, I wanted to show you here in this graph, you have the assisted vaginal birth rates in European countries. So you see from the top, we have Romania and Croatia, which have very low assisted vaginal birth rates, but you have at the bottom countries with rich, 15% cesarean section or assisted vaginal birth, like Ireland and Spain, and then plenty with a 10%, 11%, 12%. What happens outside Europe? Well, this is a completely different picture. In the graph on the top, we have Africa, showing in blue, where we see very low assisted vaginal birth rates at national level, most of them around 1%. Then in green, we have Asia, which is a little bit higher, but still, except for Cambodia and Japan, all of them below 5%. Compared with the European rates, this is very low. And also below is the Latin America, where you remember the cesarean section rates were highest. Here, the assisted vaginal birth are also very low, around the 2% at best. So here again, we see large inequalities of such an important life-saving procedure as it is assisted vaginal birth, large differences between the high-income countries and the low and middle-income countries. What are the factors that are affecting the use of assisted vaginal birth? Here, we're going to speak to your answers in the Mentimeter. Well, these are factors that have been reported in the literature. And first one, the lack of functioning equipment, particularly in low and middle income countries. There is a lack of useful instruments that are appropriately ready for use, instruments that work. Some parts in vacuum, some parts are not working, some parts need to be fixed, they are never fixed, and it's a constant a problem. There is also the problem of lack of adequately trained staff to indicate and perform assisted vaginal birth. I want to make a note here that training is needed not just to conduct the assisted vaginal birth, but is to recognize when a woman can or may benefit from assisted vaginal birth. So this is going back to physiology of labor and childbirth, to identify that moment in which we have to decide when the women the assisted vaginal birth will be useful for the women. Also, you mentioned lack of guidelines on how to perform assisted vaginal birth. This is a global problem. There's lack of international accepted guidelines that can be adapted and adopted at country level, and this is used for declining access. There's insufficient or suboptimal supervision and support to newly trained actors that need to build their expertise gradually. As you said, it was your first fear and concern is the maternal and fetal safety. This is really a concern because it's more and more widespread that cesarean section is safer and is safe. Then we have the fear of complications and litigations in case of adverse outcomes. There are countries in which the punitive blame practices towards junior doctors or midwives, where midwives can conduct an assisted vaginal birth, are a real barrier to move forward into deciding on assisted vaginal birth. And last is the power struggles, and potentially between university hospitals, teaching hospitals, and other hospitals that have been described in the literature. This results in disincentivizing assisted vaginal birth in favor of a cesarean section in the second stage of labor, which, as I said, is often perceived by providers and women as safer and easier. And this is what is called the phenomenon too much too soon. And also, these factors incentivize assisted vaginal birth in favor of complicated and late referrals that jeopardize the lives of the women and babies in settings where cesarean section is not available. And this phenomenon has been called the too little, too late. And why this is a problem? This map actually shows you where the problem lies. These maps actually shows how cesarean sections are disproportionately threatening the lives of the women and the babies in low and middle income countries. You see there the red and yellow color, which are the cesarean section, the deaths following cesarean section per 1,000 cesarean section. These are rates that, for example, in sub-Saharan Africa, 1 in 100 women who had a cesarean section will die. This is 100 times greater than the risk of dying a woman has in UK after a cesarean section. And the babies do have a similar fate than the mothers. So again, this map shows how cesarean section can be very dangerous in low and middle income countries, and how even if we resort to cesarean section before assisted vaginal birth, this could be a big problem in certain settings. WHO has echoed this problem, and as you know from last seminar in September, in 2015, WHO issued the statement on cesarean section rates, where it was calling attention to the high use of cesarean section and how cesarean section, how we shouldn't aim for any rate of cesarean section, but more we should strive to achieve that all women in need of cesarean section actually get one. 2 years later, WHO, in recognizing the importance and the growing importance of the non-clinical factors in the increased use of cesarean section, WHO published their recommendations on non-clinical interventions to reduce unnecessary cesarean sections, and also recommended the use of the Robson classification to monitor, assess, and compare cesarean section rates. Lastly, last year, to complement, WHO issued the statement or the technical brief on assisted vaginal birth in aiming to support research and targeting research for the use of assisted vaginal birth, and trying to the international audience and the international community to align into what research is needed. And again, this statement was is trying actually to build consensus on what is necessary to overcome these barriers. And I'm just going to describe a little bit the technical brief. The technical brief started by conducting a literature search. So all the recommendations are evidence-based. They are based on what it has been published, on the evidence that has been proved effective, of the evidence that has been shown in the literature. But not only that, this is just the first step. WHO also gathered last year technical experts, so they could put together, they could suggest where are the research gaps, and advance the understanding on how to optimize the use of assisted vaginal birth, particularly in low and middle income countries, which, as we've seen in the graphs, are the countries that could benefit most and actually where it's being used less. And that was not all, because who are the stakeholders of assisted vaginal birth? Also the women. Women are the ones that are going to have implemented the intervention. So WHO gathered and conducted workshops with women's representatives to incorporate the women's views and the perspective of these women in the research gaps and needs that had been identified by the literature and by the expert group. What would the experts saw or thought? And I'm just going to spend a little bit of time on giving you the experts' views and then the women's views. The expert says communication is absolutely essential. We need, as you said, we need to communicate well with women. We don't know what are the most effective ways to communicate and disseminate information among women. How can we actually teach women what is an assisted vaginal birth and what are the risks and benefits without scaring them, and making them understand that this is a life-saving procedure and that it has risk, like cesarean section, but the benefits most of the times outweigh the risks. Also, regarding communication, the quality of the information that is available needs to be assessed. We know women are exposed to all these social media, cultural ideas that are affecting women's choices, and we don't know how effective or how good the quality of that information is. And there needs to be research on that aspect, as well as in the role of mass media and social media. What is the role this media could actually play in informing women? What is there miscommunication? Is misinformation? All those things need to be clarified, because these channels can be used and have a huge potential. The second question that the experts saw very important is, what are the effective components of education and training? So we tend to train, we tend to do lectures, we tend to do didactic sessions, but are those really effective? How do we train our healthcare providers to identify and conduct assisted vaginal birth? And also, they were very focused on the need to address the management of the complications. So it's not only to identify which women can benefit from assisted vaginal birth, it's not only training on how to conduct an assisted vaginal birth, it's also training about how to manage and deal with the complications. And I wanted to show you a video on this education component. It's a very short video. Let me play it. You see how in Formula One, people are trained, all the components of the team are extraordinarily trained. So see how they do. How they change the wheels in just 1 or 2 seconds. How can we do? Why can we not do as good as they can, as good as they do? How do we need? This is what we are referring to here for training. What type of training would take us to conduct, assisted vaginal birth with the perfection that they reach in Formula One? Then moving on, we have the experts also suggested that studies on safety and feasibility and effectiveness of new technologies would be important. So we've been with the forces and the vacuum for decades or even centuries. Is there innovative research coming? We should look for innovative technologies that can improve or can reduce the bad outcomes or increase safety. Also, studies on assisted vaginal birth versus second stage cesarean section. Not everybody's convinced that an assisted vaginal birth is better than a second stage cesarean section. We need to engage the professional associations at country level, because they are the ones that need to endorse, and they need to get engaged in training and endorsing the evidence-based clinical guidelines and assist in disseminating. So this is as per the experts' views. As per the women views, this is also very important, because women are actually stakeholders, are partners in this issue. So women's think that the baby's safety is paramount, as well as also the complications that they may suffer. But they really is their first priority. The baby safety should not be at the stake. Women consider that is actually, they need to emphasize that labor has to be recognized as a physiological and dignified human process. There is not a pathology, but it's physiological, and interventions should only be used when needed. They don't look for interventions unless needed, and they want the recognition that this physiological process needs to be respected as much as possible. They also consider that education is key to avoid misconceptions. Access to correct and biased information is conducive to empowerment, and also agree with the healthcare providers or with the experts that how to effectively inform women is fundamental. As well as the experts, also women considered education and training of professionals is essential. And how to train at point of care would be, it is the cornerstone to good clinical outcomes. Interestingly, they spoke about the integration of the role of midwives in assisted vaginal birth. I know midwives in Myanmar are not entitled to conduct assisted vaginal birth, but it was the case that the women in the workshops talk about integrating midwives. Also, there is a great concern among women for the prevention of disrespect and abuse or over-medicalization, as we mentioned above. And also, they have empathy for the healthcare providers because they are concerned about health systems that have overwhelmed providers. They are concerned about the lack of infrastructure and the lack of equipment, and sometimes the pervasive incentives that actually foster healthcare providers to conduct a cesarean section. So all this has been done on the desk with healthcare providers or women talking about what is needed. But let me give you a little bit more of a practical picture. WHO has over the last few years, engaged in various studies aiming at optimizing the use of cesarean section and assisted vaginal birth. Here, this is the case of QualiDec. QualiDec is a study that is being conducted in Thailand, Vietnam, so these are the countries closest to you, also Burkina Faso and Argentina, as is shown in the map. And QualiDec started in 2020, and it will finish next year. And the objective is to implement a strategy through quality decision-making between healthcare providers and women to optimize the use of cesarean section. And this is a multifaceted intervention with 4 components. So we are implementing 4 components that are non-clinical. And this is because of the recognition, as I said, that non-clinical factors are driving, importantly, the increase of cesarean section worldwide. These non-clinical interventions are shown in the left-hand side of the screen. You have the labor companionship at labor and childbirth. You have opinion leaders, so these are champions at the hospital or at the setting, motivating healthcare providers to use algorithms or clinical guidelines, evidence-based clinical guidelines, of course. Then there is a component on cesarean section audit and feedback, by which cesarean sections are assessed on the appropriateness, and then a feedback on how or where improvement can be made is shared with the healthcare providers. And then lastly, there is a decision analysis tool for women. It's a little booklet that contains information on pros and cons or risks and benefits of cesarean section, and also has a section for the women to understand her feelings and her priorities to make a more informed decision. So again, this is the QualiDec study in which WHO is engaged. A second study is called C-Safe, and C-Safe is a similar approach. It's a strategy or has the objective to implement, co-design and implement and evaluate, again, a multifaceted intervention strategy which targets health professional and pregnant women and healthcare systems to reduce maternal and perinatal mortality and morbidity following cesarean section in low and middle income countries. And C-Safe has 3 approaches. The first one is to conduct appropriate cesarean section only when cesarean section is appropriate, so when it's needed. And this is done through the accurate reporting of cesarean section indications and monitoring and giving feedback, sort of the audit and feedback in the previous study. Then there is the Safe C-Safe component, which actually aims to, through intraoperative procedures, so the technical and the surgical and medical and anesthetic procedures, which are selected as evidence-based, this aims to optimize outcomes for cesarean section. For those cesarean sections that are actually needed, this would, optimize outcomes by selecting the evidence-based techniques. And lastly, the reduction of unnecessary cesarean section, the last component, which would be achieved by facilitating safe vaginal births, respectful vaginal births, and in particular, implementing assisted vaginal birth with the right techniques and the right training. Lastly, I would like to tell you about one study that actually has not started. It's a proposal, very focused on assisted vaginal birth. And it would also be, the objective would be to co-design and implement and evaluate also a multifaceted strategy to the appropriate use of assisted vaginal birth with focus on low and middle income countries. And this would have the focus on midwives, because these midwives are the main providers of birth in many low and middle income countries, and particularly in remote areas or settings or low resource settings. It may not be the case in Myanmar, but in many countries, particularly in Sub-Saharan Africa and others in Asia, these midwives are the main providers of care in childbirth. So the study that is being planned will have three steps. First, a formative research to understand what are the main factors driving the low use of assisted vaginal birth, as well as the feasibility and acceptability of assisted vaginal birth, sort of the same exercise of the Mentimeter that we had to understand what are the barriers. Then there will be the implementation phase, which we are proposing with 4 components. The first one is the training, which can have different forms, as shown there, like on lectures, but on-site hands-on supervision, checklists, and guidelines. Then the provision of the instrument, the audit and feedback, and also the education and information for women for decision sharing. This would be the possible or potential interventions or components to be implemented. And lastly, the study will have a component that will evaluate the effectiveness of this intervention. And I would love to if you have any comments or any views or opinions on such a study, I would love if you can put them in the Q&A channel so we can collect this information, and it will also help us to improve or change things in this study, make different proposals that actually come from the real field. So just to finish, the key messages of the technical brief would be that access to high quality assisted vaginal birth is essential if we're going to reduce particularly adverse outcomes from cesarean sections in low and middle income countries, and because we don't need more invasive interventions if we can do it less invasively. How assisted vaginal birth is perceived by women and how to inform women is important to understand, and research needs to be conducted in each country or in each setting to understand this, because this will make the basis for interventions on this front. Similarly, the most effective ways to train health providers, we've been insisting on this because the training is cornerstone in order to achieve high quality assisted vaginal birth, needs to be defined. And this includes clinical skills, but also effective communication with women and also between healthcare providers, situation awareness, shared decision-making, informed consent, how to build positive relationships with the women. So it's just not training as a small word is training as a big word. Also, internationally accepted evidence-based and comprehensive assisted vaginal birth clinical guidelines are necessary to be developed. And as we said before, not only when and what, but also what to do if complications arise. Talking about the health systems, the enabling environment is important, how to change the culture of health care. So pregnancy and childbirth is not perceived as a pathology, but as a physiological process that needs to be supported rather than intervene. And lastly, engagement of women and healthcare professionals throughout all stages of any research is absolutely essential. So research can become and can be more useful, and the uptake of the research will be more effective. Thank you very much for listening. And over to Myanmar.